This is Lisa with the Two Bad Nurses podcast.
I'm Yomi Richardson.
All right. Today, our topic is going to be talking about hospice. I've been in the hospice field for about the last 20 years. And come to find out, there's a lot of things that people do not know about hospice and end of life. And it's really important. I think it's a really important topic that we need to touch on just because there's not enough education about it. A lot of people think of hospice as just the last couple of days or the last few hours, when really it's a lot more than that. So we're just going to kind of get into it and talk about what hospice is.
Mm-hmm.
Yomi, do you know anything about hospice? What's your experience or what's your thoughts?
So, as case managers, we connect patients to hospice providers, and then the teams, they do a lot of palliative care consults. So, to be very candid, before I did my senior project on palliative care and hospice in general, and it was looking at a unit at the organization that I work for and how to connect nurses to palliative care. That was the project. And so, in doing the research, it really illuminated me to the fact that there is a difference between hospice and palliative care. And a lot of the assumptions that I'm confident you'll get into, I
Mm-hmm.
held. And it literally was like a light bulb turning on to say, like, okay, it's not what we think it is. So
Right.
I'm anxious to hear, what you have to say here. And you're the content expert on this.
Well, hospice is end of life care and it's comfort care. And the difference between hospice and palliative care is with hospice, you have to have a doctor has to give an order and say that you need hospice because you have a life limiting illness with a prognosis of 6 months or less. You do not need that with palliative care. Palliative care is pain management, comfort care. It could be any of those, but you don't necessarily have to have a prognosis of 6 months or less. So that's the main difference. Um, with palliative care, it's similar to home health sometimes, depending on what program you're in. Like we used to have a palliative home care program where you had case managers like you do that come into your home with hospice. But they're there to mainly manage your symptoms, but you are able to get physical therapy, lots of things that the normal hospice patient is not going to be getting because it's not as aggressive. With palliative care, you can get as aggressive as you want to. You can go back to the hospital anytime, you know. And with hospice, there's limitations. So, for example, if you have Medicare or Medicaid and you elect the Medicare or Medicaid hospice benefit, that replaces your Medicare and your Medicaid. So it's now you are Medicaid or Medicare hospice. It's you no longer have the regular Medicare or the regular Medicaid, and that's not in, so basically Medicare and Medicaid hospice benefit is going to cover everything that's related to your primary diagnosis of why you're on hospice. So it's going to cover everything related to that. I think what confuses a lot of people is thinking, oh, if I come onto hospice, I can't go to the ER. I can't do anything if I want to get aggressive. What if I change my mind? What if I, want to do something like that? Well, with hospice, you always have rights. You can always change your mind. You can go to the hospital. You just have to notify your hospice provider that you're deciding to go back to the hospital. And the reason why that's important is because you need to sign a paper that is going to get you off of hospice, revoking your hospice benefit.
Mhm.
That way, your regular Medicare or your regular Medicaid is going to kick in and pay for that hospital bill.
Mhm.
Because once you've elected Medicare hospice or Medicaid hospice, it's only going to pay either the hospice or the hospital, not both.
Mhm.
So you always have rights. You can always go back to the hospital. You can always do what you choose you want to do. Even if you change your mind at the last minute, you could say you were a DNR, you didn't want any treatment, you wanted, comfort measures only. And at the last minute, you say, I want to go back to the hospital. I want to fight. You have that right. You always have a right.
Hmm.
You just need to notify hospice because, for your benefit, so that you're not stuck with some outrageous bill because Medicare is deciding who are they going to pay, hospice or the hospital.
Mm. So, Lisa, what if patients don't notify? Because we definitely, I'm glad you brought that point up because this is education for me. Because
Hmm.
we have a lot of patients that are on hospice, they come back in, they have, no, maybe they have. I think it goes, I've encountered both ways to where they have notified the hospice provider because
Hmm.
when we call them, they know. They like, oh, yeah, the patient's back in the ER. And then sometimes they don't know. So if they have not notified that provider, and it's usually some kind of health crisis that they get in and they just come to the ER, what do they get billed?
Yes.
Mm,
If
wow,
if we
that's
if
no.
we have up until midnight of that day to sign that revocation form, so
Oh,
that so that Medicare will, and this is just Medicare and Medicaid. If they have private insurance, the private insurance, usually we have a contract with them and they have their own stipulations. Usually with private insurance, you can go to the hospital.
hmm.
Um, but with Medicare and Medicaid specifically, and the majority of elderly patients are on Medicare. So a lot of times we have a high population of Medicare patients. And so I think that's the main thing, even culturally, like what I tell my mom and just people with language barriers.
Hmm.
It is so hard for them to understand that we're not telling you you can't. You have the right. And a lot of people say they don't want to come on hospice because they don't want to be told that they can't go back to the hospital. But you can always change your mind. And if you decide you get to the hospital and there's nothing they can do and they send you back home, you can always come back onto hospice.
Hmm.
We would just have to do a readmission because you signed off. And
Hmm.
then there's Medicare has these benefit periods. Are you in your first benefit period, second benefit period, third? Once you get past the second benefit period, I mean, there's things like now you've got to meet with the doctor face to face, and they have to evaluate you and make sure you're appropriate because now you've been in this 2 or 3 times and been back to the hospital.
Hmm. Hmm.
So I mean, it is a bit complicated when you don't understand it, but I think the main takeaway is that hospice provides comfort care for end of life, and our goal is to provide everyone with, I mean, we know what the diagnosis is, we know what the outcome is going to be. I mean, at this point that you've been sent to hospice, the doctors have pretty much said there's nothing more they can do.
Hmm.
And so we're trying to provide a comfortable, peaceful transition, into that end of life. And that is our main goal. We don't we don't want to tell a person or their families what we think they should do. We just want to support what they want. And if
Hmm.
they choose aggressive treatment, we have to support that. And if they choose comfort measures only, we definitely will do that in the home.
Hmm. Lisa, if a patient survives beyond 6 months on hospice, how frequently is that, and then what does that look like?
Well, it happens. It's not frequent, but it does happen. And
Okay.
what they do is they have interdisciplinary meetings every month to follow and track each patient. So the doctor, social worker, nurse, everybody sits in a meeting and they discuss the progress on this patient. Are they declining? If a person is been on hospice and they're going on 90 days and they're exactly the same and there's no change, and or they even get better, we discharge them off of hospice.
Okay.
So it's not necessarily a horrible thing to be discharged off of hospice. That
Hmm.
means you're doing great.
Hmm.
Some people get really angry when you take them off of hospice because hospice is paying for their bed, their medications, and all of that, their oxygen, all of that. But if there's no cause and you keep that patient on service on hospice, that's really fraud
Okay.
because you're getting paid, your hospice is getting paid a certain amount a month to take care of this patient. And if they're not appropriate for hospice, we're required to discharge them.
That's a good point.
Yeah. It's
Wow.
really, I've been to a patient's home before who had passed away, and the person taking care of him, she said, "Oh, I'm on hospice too." And I said, "Oh, she was running a daycare, 10 kids."
What?
And we're like, "Yeah, I don't know if that's
Mhm.
really appropriate,
Mhm.
because you need, I mean, if you're able to be the caregiver of this guy plus run a whole daycare, what are they doing and how are they documenting your decline?"
Right.
And if,
Life-limiting illness.
yeah, it's
Life-limiting.
just, it's
Yeah.
not too limiting. But I remember sitting there that night going, because, and there's a big difference too, because there's for-profit hospices. We're a non-for-profit where I
Okay.
work.
Hmm.
Um, For-profit hospices, everybody has their own way of doing things, marketing and whatnot. And there are some reputable hospices. I mean, I know we have more than 30 hospices just in our town, just in
Hmm.
Kansas City. There's
Hmm.
30. Um, not all companies are going to be good companies.
Hmm.
And, I feel like actually my calling and what I do this for is for the patients. It's not about anything else but making sure they're comfortable and they're at peace, because I know there's going to be a time that my family members, myself, all of us are going to reach a point where we're at end of life. That's just going to happen. And it's so important to me to know that you're with an organization that is caring about you, and they want to make sure that you're okay, that you're not in pain, and that you're supporting the family just as much as you're supporting that patient.
Hmm.
And it's really hard because people are at their wits' end. By the time you get to hospice, you have been through the hospital, you've done chemo, you've done surgeries, you've done tests. I mean, you name it, they've been through it, radiation, everything. And by the time they're like, okay, there's nothing else we can do, we need to refer you to hospice, they're angry because they may have been told at Thanksgiving you have pancreatic cancer, and by Christmas you have a couple weeks to live.
Hmm.
It's things like that. It happens really fast sometimes, and those are the patients that you're going to get that are angry and are just mean and angry, and their families are mean and angry. And it really takes a special kind of person to really understand that anger is not towards you. That anger is because of what they're going through.
Hmm.
And you have to just be able to be supportive, non-judgmental, and calm, and not take things personally, and just understand.
Hmm.
Because
Lisa,
yeah, go
oh,
ahead.
no, I'm sorry. Go ahead.
No, I'm just saying we've seen all the emotions.
Hmm.
Each person is going to be different, and so
Hmm.
and believe me, we've seen the big range of emotions from,
Yes.
a guy who's 22 with a glioblastoma, brain tumor, versus a person who's 90 years old who's lived a long, wonderful life and is just declining. Maybe has some Alzheimer's, but is just declining, losing weight, not eating, those kind of things. When a person is at their end of life and you've seen that they have had this wonderful life and they have their family there, it's a lot easier to accept and to just, like, that's the natural progression of life.
Hmm.
When you have someone who's in their 20s, it's not and their parents are there taking care of them. It's a
Yeah.
whole different story, and it's a lot harder.
Yeah. Lisa, I got a couple of different questions here, but on the point that you're making now, I was this was not hospice related, but it was a patient and she was in her 90s and she was newly diagnosed with a cancer and she was so angry about it. And I came in, when I was talking to her one time, I told her, I said, I understand your anger, definitely, but you're in your 90s. What about young children that haven't even begun to live a life? And, she would tell us these stories about her life and, how she traveled. I said, there are some people. So I was trying to get her to see the blessing in that even though you do have this diagnosis, you've had a life. Some haven't even gotten started, but for her, I couldn't make that connection. And the fact that I was offering that made her even angrier. So, because she was like, "You don't know," which is true. I haven't been diagnosed, but do you? I guess how do you deal with those kind of patients on hospice, and particularly, does the business model kind of? It shouldn't affect the employee, but does it kind of factor into that?
Well, you for me there when there's anger, I guess I guess it's just individual. It's I can't really say. It's
Mhm.
each person is different, and you
Yes.
have to handle each person. You have to get really good at reading the room.
Yeah.
You've got to be, I mean, you have to be really good. There are some people that want it straight. Give me it straight. Just tell me
Mhm.
what it is. And other people are just like, don't say the word hospice around her.
Yes.
So you have to know what you could say hospice and they automatically want to kick you out. Didn't I tell you not to? I didn't know, because you got to introduce yourself.
Mm-hmm.
You got, oh, well, you just say you're the nurse, you know? And I don't feel comfortable because it's kind of
Right.
like, I, I got to introduce myself and where I'm from. You know what I mean? I think, but some people will say they were not allowed to say, we can't wear our name tags.
Mm.
And
Mm-hmm.
so there, and then other people are like, tell me the truth. I just want it the way, So it's
Yes.
really hard. You've got to get really good at knowing when and what is too much, you
Mm-hmm.
know? So, for example, I went to a patient's home one time and he was dying. He was within probably his last 4 or 5 hours of death. He had a daughter that was very controlling, and all the nurses were like, oh, she's really hard to deal with because she's very angry and she wants everything written down and she wants, all these things. And she was writing down all his labs, when he was going to get his labs, when was his next blood draw, PT, I mean, just everything. Blood sugars. I mean, we're talking last 5 hours of life,
Mm-hmm.
we're 20, at least 24 to 48 hours. I could tell as soon as we walked in. So she was like, so what's his blood? Where, she was giving me all his lab values. When's his next lab draw? And I just stopped her and I said, listen, I know you've always been in charge of taking care of him, and that's what you do. You've been an advocate for him, and he is so lucky to have had someone like you because there's so many people that are out here alone. So thank you for being that person. But at this point, he's not going to get better. He's dying. And you can use these last few hours to write down all your labs in your notebook, or you can go in there and hold his hand and tell him what a great dad he is and talk and have memories and tell him how much you love him and how you're going to be okay and give him permission, that it's okay to go. And she was like, wow, you're right. And
Mm-hmm.
she went in there and and literally he probably, let's see, I was there about 8 o'clock PM. He died about 3 in the morning.
Mm-hmm.
And she thanked me and called me the next day and told me how grateful she was. She said, because if you wouldn't have came over, I would have spent those last hours at going through my journals and notebooks and getting all his paperwork in order. I
Mm-hmm.
would not have spent time with him. And I spent several hours and we laughed and we joked and she said it was I'll never get those moments back. And
Right.
you opened my eyes. And to this day, that was probably 2008,
Mm-hmm.
and she still sends me cards and calls and Christmas cards and because sometimes people just remember that. They remember that more than any technical thing that you did, lab draws or, they remember that support and those meaningful words that you said because that is going to make, they're going to be able to live with themselves and know that they got those last hours and they said everything they wanted to say, no regrets.
Mm-hmm. Lisa, do you find, I guess, honesty in healthcare? Because definitely out here in California, I feel like we have a lot of veiled conversations where, it's a very litigious state. People will come in saying, "Oh, I have my lawyer here," just looking for wrongdoing, and kind of that stress response that you mentioned that keeps people kind of micromanaging and looking on what to do.
Mhm.
And as healthcare providers, I have found out here in California that they will be less than honest. The physicians, the physician will set the tone, because if the physician is not forthcoming, then the
Mhm.
rest of us as nurses, we can't go in there, divulge in anything. And so that honest conversation, which is needed to kind
Mhm.
of recenter, because it even happened with me and my dad, to
Mhm.
where when he was dying, and the neurologist came in and she said, because they were saying, "Oh, he'll never move his right side," but he was actually lifting his arm. And I'm like, he is moving, he's doing it. And now we 20 something years in the game of nursing.
Mhm.
But because it was my dad, I was looking at him, but I wasn't able to see. And so when she told me, she said, he may have these little movements, but is it enough to sustain his body and his functions and his lifestyle? And that was like, you're correct. I didn't even think of it that way.
Mhm.
But to
Mhm.
have that honest conversation, and I feel like we do our patients a disservice when we're not honest with them. Whether they don't process the information, they may be processing it. We have to give them time, but at
Right.
least give them a reality, the true reality. So that way, I had a doctor that the husband, he was talking, but he was critically ill. And we all saw this, but he did not let the wife know how critically ill he was. And then he ended up coding, intubating him. And Lisa, before that shift ended, he died. But that wife came back and she told the attending, she said, "I wish you had told me this morning how sick he was. Because if I had known," because they'll use this language, "Oh, if we can just get over this hump, if we could just get over the four pressors, the
Right.
CRT, and the intubation, he'll be okay, this massive infection." And as
Right.
nurses, we're just kind of like, seriously? But she was like, "If you had told me how sick he was, that in that those last moments would have been different. We may not have intubated because I would have wanted to have heard his voice, and to the point you're saying." So
Yeah.
do you find that in hospice that you're able to have those honest conversations, and just broadly in healthcare? What is
I
this?
feel I feel like hospice, I've been able to have those conversations
Mhm.
all the time
Within
because
the context of doctors? I'm sorry. Does the doctors influence that?
the doctors, well, they're in their home, right? So we're going into their home. We're in a private setting. They're not in the hospital. The doctor's not there. The doctor's not knowing anything other than when we call the doctor to get new orders, increase medications, or notify him of something. When we're there having a conversation, it's just all of us at the table. Family, patient may be there, you're talking, and you notify the doctor when you need to. So I think they feel a little bit more comfortable because they're in the comfort of their own home. When you're in a hospital, it's a sterile, cold. It's not your couch.
Yes.
It's not, and so it's different. And I feel like there are so many doctors, and a lot of the not our hospice doctors are wonderful, right? But a lot of the primary care physicians that refer the patients to us, they are not comfortable having that conversation about end of life.
Mhm.
They just refer them to us and expect us to have the conversation. They are not comfortable with it.
Okay.
And I think that is one of the worst things when you haven't spoke to that family and told them, you just write a consult and all of a
Mhm.
sudden we show up and they're like,
Mhm.
what's going on? And I just a couple weeks ago, we were being one of the nurses, I was doing a supervisory visit on her, and she went in and said, "Hi, I'm with hospice." And he was like, what, the doctor just left, they didn't say anything. She's like, "I'm so sorry, they told us to come in." And he goes, "Well, wait a second, what about her dialysis? I thought she was to."
Yep.
No one had even told them that they needed to stop dialysis. No one had told them anything.
Yes.
And that was, I felt, he was in tears. And I
Mhm.
told him, I said, "You know what? I don't expect you to make a decision about anything right now because this is all new to you. I'm going to leave you some of our information. Read it over, talk to your family. When your brothers and sisters get here, talk about what your goals and expectations are. Do you want to continue dialysis? Because that's definitely your choice. Do you want to stop it? How has she been? Do you feel it's beneficial? Is she tired of going 3 times a week? What is her quality of life? And if you feel like she's still got some fight in her and you want to keep going, go for it. And
Hmm.
I said, and I think this was completely wrong that they called us in here and didn't even tell you. I feel bad. I was apologizing. Like I felt
Hmm.
bad for even being there.
Hmm.
But that's just wrong. I mean, that's wrong. That's one of the things I've seen that is really wrong.
They do it for us as well, kind of these consults without consultation, and the nurse is the first person, going in. For us as case managers, we definitely ask the doctors. I do. A lot of us do. Have you spoken to the family about hospice? They put in that order, and they're very good, I will say, about having talked to the family about hospice, and palliative care has been involved. But for us as case managers, a lot of times what I see is I like to call the family when I get the order, and I'll say, "Hi," introduce myself. I understand that you all are interested in having. I always start with an information only session. Even
Hmm.
they may know they want hospice, but I'll
Right.
say, "You're interested in an information only session with hospice," and I'll say kind of a weird question, but do you have experience with a hospice agency? Because some families have.
Uh-huh.
But to introduce, because what I have encountered is that if the case manager just sees the hospice order and refers it out, and now families are getting called by several different providers, that makes them angry. And then they're like, was anybody, the doctor mentioned, but was anybody going to talk to this? And we don't know. You just may want one provider. You may have experience. But if we as the intermediary don't have that conversation with the family, it's like it does them. And I don't know that people understand that. Like,
No, well, just because a doctor could be a great doctor
hmm.
doesn't mean he has great communication skills, you
Hmm.
know? And so, I mean, I always laugh because when I was working in the recovery room, we had an OBGYN doctor who had trouble saying vagina.
Mm.
But he was an OB doctor, right? And so we were going over the discharge instructions of like a surgery, like DNC or something, where no tampons, no sex, no intercourse, nothing per vagina for 6 weeks, or
Yes.
until follow up. I'm saying it. The doctor comes over and he was going over the instructions, and I heard him talking to the woman and her husband. He goes, "So for the next 6 weeks, nothing, down there, nothing, and they were just looking at him. I was like, no sex,
Right.
no tampons, nothing inserted in your. He was like, oh, thank you, thank you. But I'm like, well, how can you be an OB doctor and you can't say that word?
Right.
But some doctors can't say dying.
Hmm.
He's gonna die or he's dying, or he's in
Hmm.
the dying. They'll just be like, well, no, he's got a long road ahead of him, or just they
Yeah.
just can't say the words that we're at that point.
Hmm.
So that's what I've learned is it's about who can communicate the best. When it comes to end of life, it's not a surgery to perform, it's not a skill, but it is a lot of communication. You
Hmm.
know, having empathy and understanding where people are coming from, especially if they have young children. And we have a pediatric hospice too.
Hmm.
So that makes it even harder. I can't, that's one of the things that I find really rough, um, dealing with children that are
Hmm.
dying.
Hmm.
So, what,
Oh, go ahead. I'm sorry.
no, I was just saying that's probably the hardest part, is those parents are going to be the angriest, most overbearing, yelling at you every step of the way because that's their baby,
Hmm.
and they're just going to be like that. They've
Hmm.
they've had to be the advocate of that kid for many months in the hospital when nurses weren't giving them the pain medicine, or when things weren't right. They had to advocate, and so they come and feel like they have to run the show, and if they don't, you are not going to do this right.
Hmm.
And so it's a challenge. It's a
Yes.
challenge. Yeah.
Yeah. And that's definitely the nuances of nursing that when we talk about how we're, not to make this a compensation issue, but the value of nurses, which the way we pay nurses shows how we value them. But these are the nuances because we're the ones that are directly dealing with the patients and the families and the anger and catching the kind of the brunt of that because the physicians can be in and out. And even,
Mhm.
especially like you're saying in the home setting, do you find it different um, when palliative care has been involved prior to a hospice referral?
I do. I think it's a lot easier to transition.
Okay.
They are, by the time, if they've been on palliative care and they transition to hospice, it's almost like a relief because with palliative care, you're still having to get your medical equipment, your bed, your oxygen through your insurance companies or renting them or you paying for it or whatever. So by the time it gets to where this person is completely bedbound, really, and you get hospice involved and hospice comes in, they're like, we're going to take care of everything. They're
Hmm.
like, ooh, they don't have to, you get your medications delivered, you
Yeah.
get your bed, you get your oxygen, you got everything. It's
Hmm.
all bundled. It's a bundle.
Hmm.
And so for them, because they've been on palliative and they've seen the other side, excuse me, I'm so hoarse.
Hmm.
They've seen the other side and they know that this is all stuff they need, and it's kind of opening their eyes like, okay, we know we need this stuff. It's slowly, you see the progression. And so when it gets to the point where they are ready for hospice, it's almost a relief because you're getting more help. You're
Hmm.
getting more nursing services. Nurses are coming in more frequently, and you're getting things like the medications and things to help you out.
Hmm. Lisa, the literature was saying that if a patient is on palliative care, and one of the things that was really a shock to me was that we conflate, healthcare providers conflate palliative care with hospice. And when we hear palliative care, we think that the person is going to die. But in the reality is that with aggressive interventions, palliative care should be involved because they're here to support the patients and their family in that decision making.
Hmm.
And to the point that you're making there, when it's now time to transition to hospice, because palliative care has been walking alongside that patient and family, there's one trust, there's
Hmm.
communication. They don't feel like the family or patient, like, oh, y'all just want me to die. You don't see value. I have this severe life limiting diagnosis, but
Right.
y'all just putting me out to die. But if you've engaged with palliative care, they've walked alongside you with those aggressive treatments and interventions. And now, unfortunately, if they're not working and it's now time to transition and defining, they understand what your quality of life is. When you get to that point, they can now kind of walk you to the finish line, as Courtney has said to me. And so
Hmm.
it's like, it's unfortunate when we're not engaged in palliative care, distinguishing number one, the difference between those two services, and then educating families on what it now looks like to make that hospice transition better.
Yes. Well, and you've built trust with that case manager on palliative.
Hmm.
You trust that person because they've seen you and they've helped you manage your pain and they've helped you get comfortable and they've helped you, and so they see you in the home, they see what you're doing, and you trust them. So when they've gotten to the point where they're like, I think it's time that maybe we should consider this, we should
Hmm.
consider hospice because I've been noticing that your pain is getting a lot worse. We're having to give you lots of breakthrough doses of the pain medicine. You're not moving around. I feel like your breathing is getting pretty labored, things like that, that you can point
Yes.
out. And they really, because they trust you, they respect your opinion, and it's a lot easier than someone who doesn't know you. We have a program called community-based palliative care, and that is people who they're not ready for hospice, but they have a disease process that goes, and they need pain management, they need help, they need like they have like a nurse practitioner that checks in with them, every once or twice a month, or um, they they are able to have eyes on them and see when there's a decline and when it's time. So they're not just coming into hospice in the very end stages of life, because you really, it's a disservice to have them on just those last stages when when you've got someone on for 5 or 6 months, they
Girl.
have been able to take advantage of all these services. They've been able to build a relationship, have the support. We have volunteers that come and just give caregivers a break if they want to go play bingo or something. We have different type of legal lawyers that'll come out and help do DPOA paperwork in the home. We have massage therapists that come out and just even for the caregiver, give them a massage. There's so many things, social workers that plan all these things, chaplains that give you support. And so, wow, if you just come the last week, the last 2 weeks, you really didn't get a feel for what hospice is really about.
Hmm. You hitting the nail on the head with all of the everything the literature says, and even that hospice and and palliative care and hospice is engaged too late in the disease
Hmm.
process.
Hmm.
Like in everything you just said there in terms of the services and really walking alongside that family, we
Hmm.
do them a disservice, like you said, when we
Hmm.
don't. Do you find resistance among certain specialties? Oncology. I'm just going to throw it out there like the oncologist doctors not wanting to engage with palliative care or hospice because it opposes kind of, especially in level tertiary and quaternary care organizations,
Yeah,
we're here to treat.
right. It depends on the doctor.
Mm.
We have some doctors that are, I love these doctors. Like they
Mhm.
refer to us because they know us and they know what we stand for and what we can provide and the services, and they don't want to see people suffer, right?
Yes.
We also have other doctors who are very difficult to deal with. They will not even they are the type of doctors that in the very end stages of life when a person is barely hanging on, moaning in pain, and I mean, breathing so heavy, like 40 a minute because they're in so much pain. They won't even give them morphine or they Tylenol. I had one doctor just Tylenol.
Hmm.
He just didn't feel comfortable with giving narcotics. And I'm
To a
like, but
blind patient.
what 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 is the harm when you're hours away from death?
Yes.
And you know, I always say there from just the doctors I've worked with, I've already picked out in my brain who I want to be my hospice team.
Hmm.
When it's time for me, I'm like, that's the doctor I want, that's the nurse I want. Because,
Yes.
because I want someone who is going to make sure I'm comfortable.
Hmm.
I don't want someone scared
Yes.
to give me something.
And that's not the time for battling over pain meds. I'm not here to battle with you at that
It
time.
isn't, it is not. And I mean, of course, all the doctors, all the primary care doctors right now, because of the opioid crisis, and
Yes.
they're scared. They don't want to give anything. So they just refer 'em to us. They
Mm.
just refer 'em to us. And we don't have a problem giving it to them. But prior to them coming onto service, you know, they could have been given a little bit more. I mean, they didn't have to suffer because who knows how long they were in pain before the doctor was like, I think it's time for you to go to hospice.
Yes.
You know what I mean? Like, I don't, I'm so big on people not suffering. I hate that.
And Lisa, that's an irritant to me because it's like, when we put these regulations in place, and I'm here for them on some level, but it inevitably will affect those law abiding people. And I don't know, I kind of low key don't respect scary practitioners. Like, what you afraid of? Like, if I'm doing to you what I would want done to myself, and I'm practicing within kind of my scope
Hmm.
of education and according to, why are you scared? Like to
Yeah.
say for a primary care doctor, okay, we have an opioid crisis, but it's unfair to now not medicate somebody that's in pain because people who scheme and they're going to get it anyway.
Yeah.
Just make sure they're not getting it from you. But if you're presenting yourself to me and you have a qualifying diagnosis, why are you scared to practice, medicine and healthcare? These people irritate me.
I
These
mean,
people.
and you as the physician have written the order and said, admit to hospice. I
Hmm.
certify that they have a life limiting illness with prognosis of 6 months or less.
Hmm.
You've done that. So now that you've done that, you should be able to medicate them accordingly.
Yes.
And when you don't, that is the biggest struggle I have. You and I used to work with one of the doctors at the hospital when we were in the ICU.
Hmm.
This doctor now, we knew him back then he was a surgery resident back then.
Hmm.
He now is. one of the medical directors of like a nursing home.
Hmm.
And he is the hardest doctor to get any medications from. Just, I mean, you're begging. Like, did you hear this person moaning? And I keep thinking about to when he was younger as a surgeon, and he was all, how he had all this fight in him, and
Yes,
I was like, what happened to you? Like,
exactly.
what happened? Because we're still the same. We still don't want patients to hurt.
Hmm.
Um, why do I have to beg you to?
Right.
I'm like literally calling every 10 minutes. Do you hear them in the background?
Yes.
That's not okay, and you shouldn't have to be like that. This is not the time to worry about somebody being addicted to anything and those for those last 5 hours that they're alive.
Right. Right.
It just makes no sense to me. So we all of the nurses on my team, we all have that same mindset where we're going to do whatever it takes to keep someone comfortable. We're going to follow the orders. We're going to do what is expected of us, but definitely pain management and symptom management is a huge, huge part of why we were there.
Hmm. Lisa, so I want to kind of shift, not too much, but you heard this baby that was decapitated. This story that's been trending.
Yes.
So I did a TikTok on this, and I was saying that I was waiting because how inconceivable is that a baby was actually decapitated, but for real, like the head was left behind, and then the hospital staged it. And so on my TikTok, I was like, where were the nurses? And we don't know. The nurses may have been saying like, what are you doing? What's going on? Escalating up the chain of command, like how we would have to do if we saw like a president or somebody didn't know, we're calling like get some help. This person doesn't. But RN is advocates. This is kind of my soapbox, one of our soapboxes too. We have to be able to speak up. And like you're saying with this physician that doesn't want to administer pain, because some nurses may just kind of, oh, well, we know how he or she is.
Hmm.
I'm calling you several times.
Hmm.
You're going to get tired of me
Hmm.
because
Yes.
this is the right thing to do. And I
Hmm.
feel like as nurses, we have to hold the line in terms of that advocacy for our patients. We have to. We can't let
You
that
have
go.
to. You have to. It's unacceptable. They wouldn't want their mother treated like that. They wouldn't want any. I mean, it's just unacceptable. And
Hmm.
I mean, I have called several times, and I had one doctor yell at me, cussed me out, hung up
Hmm.
on me, and told me he was the doctor. And I said to him, I'm a professional. You
Yes.
you need to have respect for me just like I'm having respect for you. I'm not calling you at 2 a.m. because I just feel like talking. I'm
Right.
calling you at 2 a.m. because this person is in pain and they need to go into the hospital for symptom management if we can't control it at home.
Hmm.
And he hung up on me. Well, about 6 in the morning, he called me back and he said, I just want to apologize
Hmm.
because his religion, he was fasting,
Hmm.
and he was like, I was fasting all day. I didn't, and I was just irritable and, whatever. And his wife then called. And so I know what happened. She heard him talking to me and told him he better call and apologize because she called and apologized
Hmm.
afterwards.
Hmm.
But it just was, I was just kind of like, I mean, it didn't bother me. It happens all the time. I'm like, you're going to respect me, or we can just get off this phone. And
Yes.
if I need to refer to our medical directors to try to get some pain management here, I will. I don't
Hmm.
want to step on your toes, but we're not going to let this happen.
And definitely as nurses, we have to have thick skin. And now that we're talking about it, I think this could be a whole nother issue in terms of RN abuse and advocacy, from because it's still going on.
Oh
It's still
yeah.
in
Oh
health,
yes.
very prevalent. But I don't know. I have some opinions on that because I feel like because our endpoint is patience, I can't have a bad day. If I'm fasting, I better go get something to eat, and I will fast a lot, spiritual and otherwise. But if I'm like, if I feel like I'm about to, I don't know, Lisa, if I'm having a bad day and I don't feel it, I will stay home. Because what I'm not going to do is I'm not going to go to work and make my patients miserable, my family's miserable, or give a half performance, half, 50%.
Right.
because it's a human at the end of this. And while we're all human and we can all have a bad day, I don't know. I get very black and white, and I feel like you just need to stay home
Hmm.
because, now that could be hours of suffering that somebody is enduring between two, when you had the conversation, 6 o'clock when you call back. Well, I do appreciate the apology because some people will not apologize, and I appreciate that, but learn from that. But now this is a 4 hour block that somebody is suffering that I'm now up trying to
Hmm.
navigate past what you won't do. Instead
Right.
of keeping the order, let us administer, we can all go about our lives. Like, what is I don't understand that.
And and I'm trying to like get them into the hospice house, into the inpatient unit. I mean, what are we going to do? We got to start some kind of sub Q line, IV. We're not managing this with oral meds.
Hmm.
So it's just it's definitely a challenge when you don't have a doctor that's on board. But at the end of the day, you have to be the advocate for the patient. And I think that's one of the main things with hospice is you have someone there that is going to advocate for you. You
Hmm.
have someone there that's going to be in your home 2 to 3 times a week, or even 1 to 3 times a week if you don't need us that often. You know what I mean? But we're going to make sure you have your medications. We're going to be looking through your medicine. Do you need any refills? There shouldn't be anybody just running out of meds, because we're checking it.
Yes.
Things like that, making sure there's stuff for emergencies. There's a little box in your refrigerator. If you have this symptom, call us and we'll tell you how to administer it. You don't have to
Hmm.
wait for a pharmacy,
Hmm.
those kind of things. And there's different levels of care with hospice. So you have routine home hospice, which is your basic, coming into the home. We're seeing you a couple times a week. And then you have acute general inpatient. It's like an acute level of care. That is when there's a symptom that cannot be managed in the home. So that at that point, you're going to go inpatient at a hospice house or at the hospital. And you're before there was hospice houses, we used to have contracts with the hospital so that they didn't have to come off of hospice, but they could still go in for symptom management because there are sometimes you cannot manage. The pain is so bad, no matter how much oral medication you're giving, it's not going to help. They need IV. They need some kind of. We've even had people on ketamine drips, and
Yeah.
there's basically conscious sedation.
Hmm.
So you have to be monitored inside a facility. You can't do that at home.
Hmm.
And so that's another level of care. And then there's a level of care called respite. Respite is when it's 5 days that you can go into a facility or nursing home or a hospice house where it gives your family a break. That's what respite is. And it's 5 days, it's no more than 5 days.
Hmm. I'm gonna look and see with our hospice providers what respite care looks like, because Lisa, it wasn't until I think it was Courtney that had asked me about a hospice house. I said, hospice is not a designation, like it's not a setting. It's or it's a designation, it's not a destination. That's what I said. And then when you said hospice house, I said, there are hospice houses?
Yeah.
We don't have them out here. Ours are in the
Oh.
skilled nursing facility. Either you're going home, you're going to a skilled nursing facility, or if the hospital has the resources to pay for congregate, we'll pay for congregate if it's kind of death is imminent, so to speak.
Uh-huh. Uh-huh.
We'll pay for congregate, but but that house, that hospice house, that's a good, I hate to say business model. And I'm gonna circle back to what you said in terms of profit versus nonprofit, but
Hmm.
it is, that's how the industry looks at it, like a business model. But it's a good one. It
It
facilitates
is.
patient.
Oh my goodness. The hospice house, I've had so many family members there. It I would not even want to be at home. I know people say I want to be at home. That place is beautiful.
Hmm.
The rooms are so large, big, peaceful, beautiful setting, big
Hmm.
windows. They have all these little stations where volunteers bring in food every day, and you've got a kitchen, you've got laundry facilities where the families can do the laundry, comfortable beds for everybody to sleep in, and you can bring your dog, you can bring animals up there. You can go outside and they can push someone's bed out there and let them sit out in all the roses and the flowers, and and
Hmm.
it's so peaceful.
Hmm.
um, we've even done things like brought a horse up there because someone wanted to be on a horse or see a horse, before they left. Um, my One of my good friends, her son passed away at the hospice house, and he was only 8.
Mhm.
And it was 2 days before his birthday, and they wheeled him outside and threw a birthday party for him. Had clowns and balloons, and I mean, these are and they did a video of that she'll always have, like,
Yeah.
just it was just, I was just so happy to be a part of that because the social workers, everyone was there, and they brought in special books that he likes to read. They brought us special toys and just different things. They set up the rooms different for the pediatric patients. I just can't say enough good things about our hospice house.
Mhm.
I mean, I've had family members that the whole family is up there, and you don't feel like you're invading space because there's
Yeah.
so much space.
Yes. Yes.
Yeah.
What's the length of stay that insurance will reimburse for a hospice house?
There is no exact length of length of stay.
Okay.
What it is each day that they're in, someone has to be seeing them, a doctor, nurse practitioner, and there has to be documentation on why they have to be inpatient. What are they getting? What symptoms are being managed that cannot be managed in the home?
Okay.
So, good documentation is really important.
Hmm.
If they're on a dilaudid PCA or things like that, that you're not going to probably, you can do that at home, but depending on the doses and if you're giving a Versed drip or something like that, there's also patients that have a lot of secretions and they maybe need oral suctioning. There's a lot of different things, but the documentation is really important for that. One thing about the general inpatient level of care, okay, is that dying doesn't qualify you according to Medicare. So even if you are at the very end stages of life, if you're laying there peacefully and comfortable, Medicare is not going to pay for you to go into a hospice house. And
Okay.
people are very confused about that. Well,
Hmm.
wait a second, they're at the end stages of life, but it's not about that. It's what symptom is not manageable at home. That's the only way Medicare will pay for that higher level of care.
Hmm.
So if a person, it doesn't have to be end of life. It could be nausea, vomiting, that's uncontrollable at home, pain crisis. People go to the hospice house, get it under control, and they go back home.
Mm.
But at end of life, usually the natural progression is that as a person starts to decline, lungs start filling up with fluid, breathing starts becoming a little bit more labored. Um, a lot of times they'll have a lot more pain that just can't be controlled. And so those, in addition to end of life, are what constitutes that higher level of care. But people, it's hard for me to explain to someone that you're in these very end stages, but you don't qualify.
Hmm.
But it's not us because we would bring everybody there if we could. But
Yes.
Medicare has their guidelines, and that's CMS across the board.
Yes.
Um, they just has to be a symptom that cannot be managed in the home.
Does Medicaid pay for hospice
Medicaid
house
too.
and the commercial plans as well?
Commercial plans do according to their contract.
Okay.
So it just depends. They're going to have commercial can, when you're dealing with private insurances, they can make the contract of however
Hmm.
they want it, and it could be a contract that's easier to get in or harder.
Yes.
Um, but I know that with Medicare, which is what we usually deal with, that you usually, when a person is that close to end of life, there's usually some kind of symptom that's out of control. There's usually something. I mean, if you can, me being a nurse, if I know this person's going to get better care at the hospice house, I'm looking for those. That's searching through the history. And if I see he's breathing hard and like his respirations are 30 a minute, and he's having to have morphine like every 10 minutes just to keep his respirations down because he's in that much pain. I'm going to document his respirations. I'm going to document how much medicine he's getting all the time. And what's going to get him qualified to get into the hospice house more than likely.
Hmm. Okay,
It's
that
just
makes.
that, yeah, it's a higher level of care. And anytime you need a higher level of care, it's a higher level of reimbursement. So
Hmm.
anytime you're getting a higher level of reimbursement, Medicare and Medicaid is saying, like, why am I paying you this higher level?
Yes,
And you better give me a good reason why I'm paying you this higher level.
exactly. Exactly. Document it.
Yeah.
They want to know why. Lisa,
Dying doesn't count.
no, no. And I can see that. And unfortunately, maybe it's the case management lens that I'm looking at it through, but I can see where just somebody dying, but they're calmly dying.
And
Like,
they're
no,
peaceful and they're
they're
comfortable.
peaceful. Like, no, I can see where the insurance would not
Yeah.
reimburse for that.
Yeah.
Go back to the for profit. How's that different than the not for profit?
Technically, it should not be any different because we're all operating under CMS guidelines, right? They're
Hmm.
all the same, Medicare, Medicaid. But I feel like there's a lot more. I feel like for us being a nonprofit agency, we have certain standards that are just, we're not the marketing. I feel like it's in the marketing that's different.
Yes. Hmm.
Um, I don't particularly think, I don't want to throw other places under the bus, but if you are getting an email, hey, we hit 500 patients this month.
Yes.
We're at an all-time high. If we get 20 more this week, you get in a drawing for a flat screen TV.
Yes.
Um, that just seems a little, that just doesn't sit right with me, right? I'm like, oh, I don't know if I want to work there.
Mm-hmm.
I don't want to work there. That's not what it's about. Like, or
Yes.
if we get 6 new admits a day, we all get a bonus.
Hmm.
And I think about that and I go, so you get 6 new patients a day. That means 6 people's lives have been affected that day. They've been given some information that day that is going to change their life. You've affected children, sisters, brothers, mothers, fathers. Look how many people that has affected for those 6 patients to be admitted to hospice that
Yep.
day. Their
Yep.
life, they were just given news that nobody ever wants to hear. The worst
Right.
news that you can imagine.
Hmm.
So how can you be like, yay, we hit 610? You
Right.
know, I just don't like that. We do talk about census in our, because, even being a non for profit, you got to make enough to keep the doors open because
Right.
we want to be able to serve.
Hmm.
And if you're sinking, you can't. So you have to be smart.
Hmm.
You have to be smart about how you're not spending. You're looking at the medications, that the cost, being mindful, of the cost. But cost isn't everything.
Hmm.
And if a person needs a certain medication, our upper management is like, do whatever you need to take care of the patient. They don't tell us we can't do an IV, we can't do this. Some hospices are different. You have to get all
Hmm.
these authorizations to do. They're just like, just take care of the patient, whatever they need. Be mindful, and if you can get uh, omeprazole or Zantac instead of omeprazole for the heartburn, yeah, get that. If you're suppository over here for constipation, we get it cheaper over here. Be mindful of that. But when it comes to the important things, what they need, they're going to get.
Yeah. Lisa, two things that you're talking about. One, the provision of services, because I have noticed with one of the major hospice agencies that we use out here that they may not provide something that another agency is providing. And I was
Mhm.
always curious, like, why is it different? Like, why are you all able to, send a nurse, why are you all able to provide a different services that another one can't? I'm gonna have to look and see who's for profit and who is not. But the other thing is that corruption, like you can now corrupt physicians into, if the goal is to just recruit patients or get patients on board to sign on, and then also nurses, because case managers, because we were having that at one point several years ago, to where people were getting gifts for signing on with the hospice agency, but now the organization I'm with, they made it very clear you're not supposed to be accepting any gifts from any vendors, and they actually narrowed the hospice agencies down. Now patients always have choice,
Mhm.
but to 3 specific hospice providers, to kind of eliminate some of that influence. And then they made it very clear to us we're not to be taking gifts, no matter how small,
Yeah.
not food or nothing, like because it influences, kind of you're saying that quota that people are trying to meet.
Yeah. It's not, I mean, you have some hospices that sit inside nursing homes and they
Hmm.
just make their own little desk and they sit there all day and just wait. They just
Yes.
wait and they hear somebody needs help. They're right there. And that's how they can get their patients really fast.
Hmm.
Um, it's just, it's sad to say, it's just like those lawyers who, the ambulance chasers,
Yes, exactly.
somebody who is like just in a car accident before you know it, you got a lawyer in the ER. You're like, do you have are you being represented by anyone?
Hmm.
And it's sad. It's sad that we live in a world that's like that. But it also feels good on the other hand to know that there's places like ours that don't we do things the right way. If
Hmm.
somebody has to be discharged, our census is going to drop, but we're going to discharge them because that's the right thing to do.
Hmm.
They're not appropriate.
Hmm.
You can't just keep people on service just because you want your numbers to look good.
Yes.
So, I mean, I think as bad as things can be and as corrupt as certain places can be, um, the other hand, when you look at it, is when you are around an agency that really has standards and really you know what to expect because it's always going to be like this time after time after time. There's no change in anything. The policy is the policy, it's the same.
Yes.
And that's the way I like it. And that's why I think I've been here 20 years.
Yes. Do you have the physician owned hospices?
We have, I don't know if they're
Where they
physician
funnel it?
owned.
Yeah.
Yeah, they're certain PCPs are the medical director of a certain hospice. So they'll
Mm-hmm.
have a board and everything, but they'll be the medical director, and of course, all their patients and everybody they know and everybody at that hospital is all going to that hospice.
Okay. Mm-hmm.
That's the way that
Okay.
goes.
And then the last thing I was thinking about was the three wishes. Are you all make a wish, three
It's
wishes?
yeah, it's I think there's a make a wish, and we I don't know, we connect people like our social workers connect people with those groups like the Make a Wish Foundation.
Okay.
Okay. We don't have it ourselves, but the social workers connect them with all the community resources like that. Now,
Mm-hmm.
there is one particular hospice I know of that it was started by some wealthy men that can do that, and they will provide trips and whatever your wish is, they will
Mm-hmm.
do it. And that's a big thing that they kind of sell. you
Mm-hmm.
know, we'll do this for you. And with us, it's more of we're going to give you good care. You're going to be hopefully not have any pain. That's our goal. But we have social workers that can connect you with all those places. Like I said, my friend whose son who passed, he went to Disney. He did the Make a Wish, but that was through Children's Mercy or one of the. But we have connections with all of the community resources. We all kind of work together.
Okay. That was another, okay, last question that I had.
Mhm.
Like, what kind of community outreach to educate patients and families on the difference between palliative care versus hospice, the need for palliative care, and then breaking down a lot of these myths that surround both?
Yeah, we have liaisons. We have community liaisons. So we have specific liaisons that actually are housed in the hospital. So they actually go in like certain hospitals and they're right there if they need them to go in and do education. We also have liaisons that are in nursing homes. So they can go and educate the nursing homes. We also have community liaisons that actually go to the physicians' offices and talk to them. And lately, our development team has been we just started talking about doing health fairs. Like you remember, like where I used to work, where we had that health
Mhm.
fair all the out in the either in rural areas, urban areas, where there's a lot of minorities, non-English speaking families. I've really encouraged that. Like my mom has really been involved in getting the word out. But just showing up to those kind of events and just having a booth or something and explaining what hospice is.
Mhm.
Because language barriers. And I have two nurses on my team that speak Spanish fluently and are taking the class to be the translators. And
Mm-hmm.
so for just them to go out into the community and talk at community health centers,
Mm-hmm.
because at community health centers, I don't know how often hospice is brought up. You know what I mean?
Mm-hmm.
So I think that it's something that our development team has just started to kind of really get to put their minds to it, and all of us work together to come up with these different plans. And the
Mm-hmm.
community liaisons are doing a really good job too.
Okay. And then organ donation. How does that factor into?
We have patients who are organ donors, and what we have to do is when they pass at the time of death, we are to notify, for example, if it's a hospital, there's usually a representative or someone that is, with the organ donation people, and we have to call them within a certain amount of time of their
Mm-hmm.
death, and the funeral home will come pick them up, and they have to do it all within this certain time. There's a time frame. Also, they're going to ask us a lot of questions. What's their weight? Do they have any communicable diseases at that time? Maybe they got ill and got caught something. There's a lot of things we have to ask, and so sometimes they may not qualify at that moment.
Mm-hmm.
But eyes, different tissue, things like that. We have a specific person. It's in the chart of who we're to call when the person dies, and they're the ones who tell us the instructions from there. Okay, I need you to this room temperature, or this pickup service needs to arrive by this time, and we need to make sure he's here by this time.
Mm-hmm.
So they're real specific.
Okay. Okay. This has been so enlightening for me.
Oh, I'm glad. I'm glad. I mean, I think it's like I said, it's something that is a topic that I think we all need to know about. It's
Yes.
hard to bring it up, but
Yeah.
it's important. It's a good conversation to have.
Yes. Lisa, I keep thinking of one more thing. Advanced directives. Do you all see that a lot?
Oh, a lot. And that's one of the very first things at the very first meeting that the social worker has
Mm-hmm.
with them is talking about it, because we need to know who the DPOA is.
Mm-hmm.
If they don't have one, that turns into, a mess. Um, but advanced directives are very important. The DNR, we have to have an out of hospital DNR, which is different than a DNR in the hospital.
Mm-hmm.
So that you can be in the hospital and have a DNR, and you come home and say, "Oh, I've got a DNR," but it's not an out of hospital DNR. It doesn't matter. It doesn't work.
That's a good point.
So we have it posted like on their refrigerator, so that if they happen to have to go to the ambulance or something, they can pull it, and that ambulance or any kind of non-emergent transport or anybody needs that with them.
Mm-hmm.
And it can't just be an order in their chart at the hospital, because now they're at home. It has to be an out of hospital DNR.
That's a good point. That's a good
Yeah.
distinction.
Yeah.
Yeah. Mm-hmm.
Yeah. So, I mean, there's a lot of, you could go on and on about every little thing that, oh, I forgot the other thing was another level of care is called extended or continuous care. And
Mm-hmm.
that is where, so we've got the general inpatient, acute level of
Yes.
care if you're inpatient. You've got respite when the family needs a break. You've got routine hospice, which is just the regular, at home, seeing them a couple times a week. And then you have continuous care. Continuous care, you have to have a symptom that you're managing in the home, and you're reimbursed at a higher rate. In order to get that reimbursement, you have to have a licensed nurse, either LPN or RN, in the home 8 out of the 24 hours. So, as long as you have 8 hours where there's skilled nursing, you can bill for the continuous care. And it's
Mm-hmm.
from midnight to midnight. So, basically, let's say we come on after hours at 5 p.m. We see someone that's really declining rapidly. They need us to be there. It needs to be a higher level of care. Well, even if we started at 5 p.m., it doesn't matter how many times you do that. 5 p.m. to midnight, you're never going to get 8 hours in, because it's
Mm-hmm.
midnight to midnight, right? So we
Mm-hmm.
just have to, and we know it. We just don't bill for that, but you still need us there.
Mm-hmm.
That's another thing that I'm saying, like, we just won't bill for that. But if you're there after midnight, then you start billing again, right? And so let's say I'm there from midnight to 4 a.m. Now he's comfortable. I can leave. 7 a.m., he starts hurting again. Another nurse from day shift comes in and they're there for 4 hours. Now we can bill because there's 8 hours of skilled nursing in that 24-hour period. It cannot be CNAs, it can't be social work, it can't be chaplain. It has to be RN or LPN. And the rest of the 16 hours can be chaplain, CNA, and all of that.
Hmm.
So there's all these specifics when it comes to
Yes.
billing, yeah, and things like that. But once you do it so much, you just know. And really, at the end of the day, probably half of them that we do, we're not going to bill for because the time frame's not matching up. But we know I have an algorithm that I created of when to start extended care or continuous care. Um, and basically, if you've talked to the doctor, you've increased orders, they are refusing to go inpatient. They don't want to go to the hospice house because some people want to die at home, and you have to respect
Okay.
that.
Hmm.
So, because my first thing is hospice house, but some
That's
people
what I
don't.
was going to ask. I'm waiting for you, and I was going to say, what's the difference between this continuous care and hospice house?
They don't want to go. These are I reserve, and the algorithm says like first offer hospice house, no, then here.
Okay.
So if they because there's so many people, no, he wants to die at home. We're going to honor his wishes. It doesn't
Okay.
matter how much he's suffering. So we have to stay there, and we have to get a portable, a PCA pump. We need to
Mhm.
access their port, do whatever in the home. And it's a lot more difficult because you don't have that 24-hour nursing care like you do there. Um, and we have to staff it, which can be a challenge because you're pulling people out of the field,
Mhm.
that has to be there. They can't leave until their symptoms are managed. But if we're honoring their wishes and their wishes to stay at home, we have to just do that.
Mhm.
So that's when we start that level of care. So I mean, there's different levels of care, and they're all, and you could see how why that one is going to give you a higher reimbursement rate. You know what I mean?
Mhm.
General inpatient, when they're inpatient, that's probably the highest, and then continuous care right up under that.
Mhm. Lisa, when you was talking about billing, so for the continuous care hospice,
Uh-huh.
you were saying that there are hours that you can't bill for that. Not
Right.
in.
So if the billing starts at midnight, you can
Yes.
bill from midnight to midnight.
Hmm.
Okay. So if you're there, you go at 7 p.m. and you stay till midnight, you can't, that's not 8 hours. You see what I mean? That's 5 hours.
Yes.
So now at midnight, the clock starts over. So if
Got
you
it.
stay all night long, now you've got the 8 hours. But every night that we come on at 5 and we go straight out there, a lot of times there's not you're not going to bill for that because by midnight, it doesn't matter how you flip it. 5 p.m. to midnight will never equal 8 hours, and we come on at 5.
Now I see now. Okay. Yeah.
So it starts. The clock restarts at midnight.
Okay. Wow.
Yeah.
The business of healthcare. What can
Right.
we say? But
Right.
it's how we get paid. It's how our retirements. I mean, it's the industry. It's an industry now, which is
It
always being.
is. It is. But if you look at what each person has to have their own goals, their own expectations of what to expect at the end of their life.
Hmm.
And mine, I want to be at home or the hospice house. I would love that too. But
Hmm.
I want to be surrounded by my loved ones, by my family, by my children. I
Yes.
want to be pain free and I just
Hmm.
want to be peaceful.
Yes.
And that's what hospice is to me. A hospital is not to me. I mean, I get irritated being in the hospital just for surgery with the cuff going off every 2 hours and
Yes.
lab draws every morning. I mean, when you know you're at the end of life, these lab draws are not going to do a thing. Um, I want to just let me like look out at the trees or let me just
Mhm.
enjoy my dog or whatever. And that's what I think that we give, and that's the benefit of hospice, and that's the biggest takeaway is that you have peace and you can die with dignity. You can die comfortable.
Mhm.
You do not have to be in a hospital getting poked and prodded and tests run on you every few hours in
Hmm.
a cold environment that only allows two visitors in at a time,
Hmm.
where you could be at home with your whole family there, or you could be at the hospice house with, 8 visitors.
Hmm.
It's just about what you want. But if you're one of those people that are like, I'm going to fight to the end, I don't care if there's just a chance. If it's a 1% chance, I want it.
Hmm.
That's totally your right.
Yes.
Totally your right. And go for it.
Hmm.
But if you do not want that and you want a more peaceful transition, then hospice is something to learn about.
Yeah, I think, and that's definitely a good point. And I don't know, I don't want to sound judgmental, but I think for patients and families to just decide, because that limbo is where it becomes hard. Because definitely speaking for nurses, our goal is that peaceful transition because, we may have experienced death, we have longevity in our profession. And so,
Yeah.
we want to make you comfortable and to kind of do this no harm towards the end of
Right.
life. But when you're in this limbo of not deciding, it's just like, this is where are we going? And for nurses to be mindful, if a patient has decided, even if it's in the hospital setting, take that blood pressure cuff off. Like, why am I
Yes.
walking in and the cuff is going off every 15 minutes? Like, this is somebody that's transitioning. Like, what are we doing here?
Yes. I don't
Advocate
know why they do that, but this
is
this
becoming,
is well, and the main thing what we do is when they're in a nursing home and we come in to see our patient, we're like, why do you have that oxygen saturation on? Their sat's going to go down.
yes,
It's going to go down. But
right,
what you need it alarming to just make everybody, because as soon
right,
as it alarms, everybody's, looking. So take it off.
hmm,
Why do you need a heart monitor on? Their heart
yeah,
rate's going to slow down.
hmm,
So treat the patient, not the numbers. And that's what
right,
we always say. If a
right,
patient's O2 sat is 70%, but he's breathing comfortably and he's like, we don't do a darn thing about it. His oxygen saturation could be 90%, but he's struggling, we're going to treat it. Because
hmm,
it's all about symptom management. We're treating the symptoms, not the numbers. And
hmm,
that's something different that what we had to learn in the hospital. The
hmm,
hospital, we look at that monitor at the same time we're looking at them. We're looking at the
yes,
blood pressures. We're not doing that. We're not treating the numbers. We're treating the symptoms only.
right. And
You
and for
don't.
nurses to advocate for that, because like even with Daddy, when we had this hope, he'll never do this, never recover, and he ended up dying. But that he had a rough night, and that morning they were wanting to take him down to CT, and so the nurse was like, I got mad at the nurse because they were like, "Oh, we're getting ready for CT." I said, "For what?" For what? He wasn't on hospice. I don't think
Mhm.
I made the for hospice, but clinically it wasn't appropriate. Like, he just had a night, he was hyperventilating. Why are we doing? But that's for you as a nurse to advocate and even to say, I don't think now's a good time. Like,
Mhm.
maybe let's revisit this and let's come back. But it was just so much like the task. That's what was irritating me. I felt
Yeah.
like nursing was just a task. Oh, we have an order for CT, let's go. Oh, I
Yeah.
have
So they
order
can note that order.
and
Done.
check off. And
Done.
I'm like, and I was like, no, explain to me why. And what is the CT going to show when the neurologist has already told me what he'll never do? Like,
Right.
what is the point of the CT? And the nurse couldn't even tell me, like, why are we doing? I said, why are we doing a CT? And he couldn't explain it.
All
And
they
I
can do
said,
is the doctor ordered it.
doctor ordered it. And I want us nurses to come back to a thinking, and to be able to even ask the doctor, but to advocate and say, well, he was just hyperventilating last night, and he looks agonal breathing, like he looks like he's dying. Like,
Right.
why are we going? And I even said to the nurse, does he look like he's going to survive a CT? But why am I having to say that? I just want us to think
Yeah.
about what we're doing. And would you want this done to you?
Right. Right. I mean, you have to, like, when a person has reached the stage in their life where they're nonverbal, they're not eating. Why are we still going and checking blood sugars every 6 hours? That was one of the things that would drive me crazy. Why? You know it's going to go down. He's not eating. What are
It
you
was
going to
the
go
cup
push
for
an
me.
D50?
It was the cup for me. Every 15-minute blood pressure cup for me. That would drive me crazy. Like, why?
Yeah. I mean, we just got to use better judgment, on things like that. You don't need to look at that. You don't need to be checking. all these labs and things like that when you're at a certain stage. There's times and place where that's beneficial, and there's times where it needs to stop.
Yes,
So I mean, I think this was a start, just to having a conversation with everyone, just to educate everyone, because until I mean, I feel like with the baby boomer generation reaching the ages that, I mean, isn't the elderly population supposed to skyrocket like soon?
yes,
Hospice is going to be really, really a big thing, because I think
yes,
a lot of people are not wanting that aggressive treatment.
yes. And the community base, as you noted, that's what the literature is pointing to. Definitely.
Yes. Yes.
Mm-hmm. Mm-hmm.
Well,
Yeah.
I do you have any other questions for me? Because I think I've
Oh,
said it all.
you have, and then some. So I've learned something new, a lot new. So
Good,
yes.
good. All
Mm-hmm.
right. Well, I guess until we see everyone again,
Mm-hmm.
goodbye.
Yes.
And comment and let us know what more information you want, and if there's any other questions we can answer.
Yes. Thank you. Yes. We'll look for the comments.
Okay.
Okay.
All
All
right.
right.
Bye bye.